Hello and welcome to our first edition of Rappin' with the Rep. I'm Representative Ken Gordon, and here with me today we have Representative Steven Walsh, Chairman of the House Committee on Healthcare Finance, and we have Dr. Elizabeth Nilson of Lahey Hospital and Medical Center. We're going to be talking about the healthcare finance law that was enacted in the summer of 2012. This law has many provisions, but among those provisions is a new focus on wellness care. Dr. Nilson has a focus on wellness, and Chairman Walsh was one of the principal organizers and principal representatives who brought the new law into fruition. Chairman Walsh, welcome, and I wonder if you can tell our viewers a little bit about the wellness provisions of the new law.
Absolutely. And first of all, Representative, thank you very much for the invitation and congratulations on your election. I know that we've already seen great things from you in the State House, and you have a long line of good representatives from the Burlington area, my former colleague Charlie Murphy, but we are excited and ecstatic to have you and your talent on board with us at the State House, so congratulations. And it's good to be here with Dr. Nilson. Lahey Medical Center, or Lahey Hospital now and Medical Center, has been coordinating care longer than most, and under the leadership of Dr. Grant, they do such a terrific job for their patients, and specifically around the issue of wellness, that it's important, I think, for those folks in the Burlington area to see and hear some of what's happening at the new Lahey Hospital. So specifically about the law, this is really the first time, I think, as a Commonwealth that we have focused on prevention and wellness as a public policy matter. We've set aside $65 million in grants. It's maybe a small amount of money in the whole scheme of things today. We spend $66 billion on healthcare, but it's enough that communities like Burlington and others are going to, for the first time, be able to apply for wellness grants and really show us what they're doing to lower the cost of wellness within their communities. Additionally, for our small businesses out there that have been getting squeezed by healthcare costs, we offer a tax credit up to $10,000 for small businesses that are engaging in wellness programs. You know, the benefit to wellness has always been that you feel better and you live longer, but there's never really been a financial incentive. And for the first time, we are actually saying to folks, if you do the right thing, if you're healthier, not only will you feel better, but the cost of your insurance premium is going to go down. And so you'll be able to see results with you getting healthier and the actual cost of your family insurance plan reducing at the end of the year. And the doctor will help you to be responsible for your wellness and prevention within your life. And you'll see not only the benefits of it from your own health care, but you'll see the benefits of it financially. Other countries have been doing this for years, and finally we have aligned the incentives correctly in the Commonwealth. And so that's one of the provisions of the law that I'm most excited about.
How specifically can we see our healthcare costs go down?
Well, as you move away from the fee-for-service medicine, which is a transactional-based medicine, which really incents the consumer to have more tests done at the hospital, and you get into more of a global-based payment, we come up with you, for example, we'll look at what is your health number? What does it cost to keep you healthy for the year? And then at the end of that year, if you and your primary care practitioner have beat that number, if you're healthier, there will be an incentive payment to that primary care practitioner, and your insurance premium will be reduced. Because we will realize then you're a better bet for the system, you're saving the system money, and your family should derive some of the benefit of that as well.
And Dr. Nilson, I see you sort of nodding in agreement because I know this is something that's near and dear to you. Can you talk a little bit about how that will affect your practice?
Sure, and thanks for having me. I know Lahey is very invested in the community it works in, and we've been doing a lot of coordinated care, as Chairman Walsh was saying, basically just based on the way Lahey is structured, but now it's actually really exciting to participate within a bigger system where we actually can focus on wellness and have it be not only sort of what we think is the right thing to do, but actually it aligns with all the financial incentives as well. So I'm a primary care doctor, and our whole goal is really to keep people healthy. And as we understand more and more about the science of diseases, it turns out that a lot of prevention up front actually can save not only costs down the road, which I think is part of what's driving the bill, but actually that other point about it's just nicer to be well, and it's better for people, they're more productive, they're happier, and so to be able to put those two things together is great. In a one-on-one situation with my patients, some of the things that Lahey's doing is trying to make sure that I have resources that I can send my patients to help them. This is absolutely a team effort, and you can see your doctor and spend 15 or 30 minutes with them, but a lot of work does go to the patient, and if we can empower them to understand about things like the importance of tobacco cessation, exercise, healthy eating, mindfulness, stress reduction, all those sorts of things, they're going to be better able to be stewards of their own health, and it's actually just going to work better for the whole health system because overall we'll be healthier.
And going back, Chairman Walsh, to what you said, if people do that, if the patients do that, there may be a financial benefit that comes back to them under this new system. Is that correct?
Yeah, so we predict that 3 years from now, family plans will go down about $2,000 a year, which is real money. I mean, when we look at the whole system, we say in about 15 years we'll save $200 billion. But that's a long time away and a big number. So I like to focus a little bit more on the near, which is 3 years from now, our family plans could be reduced by up to $2,000. And that's real money for families that are struggling in a tough economy right now. And the benefit to that, as Dr. Nilson says, is we feel better. We're more productive. We're healthier. People are working. There's never really been a program before that has said we can actually see the quality of your health improve and save you money at the same time.
What can small business do to participate or to take advantage of this new system?
Well, large businesses have had wellness programs for a long time because they can afford it. Mm-hmm. They have the capacity. Small businesses, it really, when you're thinking about your small business and whether you hire your next employee or not, you're not thinking, well, how can I put a wellness program in? But we really should be, because in terms of absenteeism, in terms of lowering your overall cost of health insurance and having a more productive workforce, it's very good for small businesses. So we want to incent them to get involved. So what we do is they'll be able to, through the Health Policy Commission in the very near future, set up a wellness plan. And that plan has to be certified by the Division of Insurance, and once it is, there'll be a tax credit available to them up to $10,000. The other thing we did is there was a lot of pushback from small businesses after the 2006 law in terms of the fair share contribution. There's really this disincentive to hire your 11th employee, and we've now eliminated that. So we've moved to what is the federal threshold of 50 employees. So with 50 employees or less, there's no disincentive anymore for our small businesses not to try to grow, and when they do grow, we want them to put in wellness programs which can alleviate some of their cost of health insurance.
Dr. Nilson, with respect to those small businesses, I would imagine that there are some businesses that don't have on-site facilities that can particularly help with some of these wellness needs. Does Lahey have a place that can help with these?
So in a variety of ways, actually. There's the Lahey Community Benefits Initiative, which is a grant institute within Lahey that actually gives small grants to local businesses, local organizations like the Burlington Police Department, the Councils on Aging, and they do it really in alignment with a lot of these health initiatives that we understand are going to be sort of high yield areas. So a small business might contact Lahey and see if somebody could come and do a tobacco cessation program or a health screening. In addition, if their employees are actually patients, we have on-site things, usually would be determined by what their primary care doctor thought about an individual. But I think both on that personal level and on a small group level, there are a range of ways that Lahey could help those companies.
Chairman Walsh, you mentioned early on the concept of pay for services, which is that I think traditionally when we go to the doctor, they arrange for a battery of tests. We pay for the services we get. We may pay for surgery or things like that. Is that going to change over time in Massachusetts?
No, it's going to be eliminated. And I should be very clear about this. This isn't anyone's fault. This is the system that worked some years ago, so it's the system we've been using. But if you present yourself today in the emergency room, you run through what I call the car wash of tests. And in today's medicine, there's nothing wrong with that. We're encouraged to test, and those tests are reimbursed. And a physician at that point might say, I'd like to have all the information that I can to make the most appropriate recommendation or diagnosis for this patient. What we've been missing through that is the coordination of care aspect that Lahey is so good at. So now if I present in the hospital under the new law, I'll have an electronic medical record. So that physician doesn't need necessarily to order additional tests because all of that information will be available to them. By 2017, we will have interoperable records in the Commonwealth of Massachusetts. Additionally then, if I have an incentive or a global payment, a coordination of care, I can do those other things or offer those other programs that Dr. Nilson talks about that Lahey is actually currently in either perfecting or creating. And by doing that, I have a global payment, so I can use the money for what's best for you as an individual. I don't have to only use the money in terms of transactional medicine. I'll give you a great example with children. A lot of children suffer from asthma, chronic condition, very, very expensive condition. Where on the insurance form does it say, I want to pay for a vacuum cleaner? Well, it doesn't. But Children's Hospital started this program where they would put vacuum cleaners in the homes of urban areas that had rugs or carpeting. What they found is that the rehospitalization rates of children were reduced dramatically. Would you rather pay for a $200 vacuum or a $35,000 hospital admission? Those are the types of things you can do when you're coordinating care, as opposed to fee-for-service medicine that's only transactional based.
And from the point of view of Lahey Clinic, I would think there would be a positive response to that approach.
Yeah, absolutely. I mean, and I think primary care doctors the country over are actually going to be excited, as I hope Massachusetts ends up serving as a national model. But as we really start to understand the determinants of health, some of it is things that happen in your doctor's office. Some of it's what happens in your home, in your grocery stores, with your choices in school lunch, a whole myriad of areas. Are there sidewalks in your community where you can go walking? There are all these different pieces, which I think for once now we're all going to be pointed in the same direction and can use this money in creative ways to actually really support a whole population of people in their well-being. And so I think Lahey, I know, wants to serve as a leader in that area. We've been doing a lot of care coordination anyway because of the practice model that we have. We're really a multi-specialty group practice all under one roof. And so it's very easy for me to reach out to my subspecialty colleagues, seek their advice on whether or not to order a test. And so I can sometimes avoid ordering a test, or I can make sure I've ordered the right one. I can get input from them to try and keep the costs of care down. But from a wellness perspective, it also means as a primary care doctor that I can tap into all of these resources and really help keep patients healthy.
Chairman Walsh, you mentioned the concept of rehospitalization rates, which I know from speaking with Elizabeth and Dr. Nilson and others at Lahey, is a concern. It's a concern from the point of view of the insurance companies, because once someone is out of the hospital, they want to get some coverage and care to stay out.
Well, today for our hospitals, it's a business concern because they're no longer being reimbursed in re-hospitals or what's seen to be preventable readmissions. And I'm not sure that we should be approaching this in any kind of a punitive way. What we should be doing is getting it right the first time and giving our primary care physicians the tools they need when their patient is in the hospital at that time. So we send that patient home with the opportunity to succeed, not the opportunity to fail. We send them home with home care, or someone who's going to come in and make sure that they're eating healthy food on a regular basis, or they can even get healthy food. We have these things called, urban deserts, right, where you can't get locally grown and healthy food within a mile of your house. All of those things can be accomplished if someone is really paying attention to your aftercare. So hospitals don't want readmissions. They don't want to see someone come back. They want to get it right? We're all competitive in this nature. Doctors want to get it right. They want to see their patients succeed, send them on their way with the best chance for them to be healthier moving forward. And the system as it's currently set up has not allowed them to be able to do that.
And as a primary care doctor, will you be in that captain's chair once the person leaves?
Yeah, to some extent, not only actually once they leave, but hopefully, especially using the power of an electronic medical record, we can identify the most vulnerable of our patients and both try to work to keep them out of the hospital, but once they are admitted, to make sure that they go home with all the right support services. We are in the process in our practice of transitioning to what's called a medical home, where this idea of my interaction with my patients will not be just limited to office visits where I see people for a brief period of time, but rather I'll work with nursing staff and other colleagues to help support patients in their home, make sure they're taking the right medications, that they can afford their medications, that they've bought the right ones, issues around diet, wellness, if a nurse can help monitor blood pressure and weights at home. And I think what else will come out of this is we'll start to have a much more sophisticated understanding of who needs to come back and see us quickly after being discharged, to who should do just fine out in the community. And we'll really be able to do it in a nuanced way where we're spending time and resources where we need to, where we can get a good return, and we're making sure that for people who don't necessarily need so much help, we don't necessarily need to be there. So it's exciting to be part of that process. We're really embarking on it right now. But as a primary care doctor, it's sort of like a dream come true that we get to sit and think about actually how to keep our patients well and outside of the traditional office visit paradigm.
Has this program been attempted before in another place? Have you modeled it after anything?
Well, there's no, there's really no new ideas, right, in healthcare, but there are a lot of best practices. So I would say that I think what we did is we looked around the country at what's working in different areas and tried to grab the best of what's working. When we look at medical malpractice, we look at some great programs that are happening in Michigan. You look at Medicare, there's some great things going on in Oregon. So you look around the country and you see, right, who's trying what? And then you look at things that have been tried in similar fashion, the old capitation plans or rationing plans, and you make sure that our plan is consumer-centric, so that we are not making the same mistake. So we're actually putting, here's what I think folks have for a long time been upset about, that they don't feel that they're making the decisions about their health care. And sometimes they don't even feel as though their doctor are. They feel as though a third-party administrator or an insurer or a payer is making decisions about what's medically necessary for them. I think this law suggests that it should be the primary care provider and the patient that are making decisions about their health care together. And we have done a lousy job of actually giving our primary care docs enough time to be able to do that, to really spend that time with the patient to make sure. And we have folks that have been doing it anyway, but it's really hard. We haven't given our own docs an opportunity to succeed. I think for the first time, we've done that. We've moved the leverage around so that consumers are in the driver's seat, their partner is their doctor, and the byproduct, again, is higher quality healthcare at a lower cost.
Many of us have probably had the experience with ourselves or our family where we're talking to a doctor, it may be a family member's in the hospital, and we're talking about a procedure or a treatment, and the doctor says, well, we'll see if the insurance company will cover that. Is that type of conversation going to be diminished now under this new plan?
Someone always has to pay, right? I mean, so I can't say that that conversation won't happen or will never happen again. I can say that you should see less of that. As you're seeing the morphing of providers and payers into one through what's called accountable care organizations or patient-centered medical homes, you're actually having the person that's making decision about care being directly connected or partnered with the payer of that care. So those decisions, so they're more in line, and it's less of a conflictual or adversarial relationship and more of a partnership. So I think it'll get easier. But ultimately, what we also want to do is educate that consumer. We have folks that are watching television right at 10 o'clock at night, and a commercial comes on where a guy's running through the field and he seems happy, and they come into the doctor, they say, I want what that guy has. So we also have to move away from people self-diagnosing and our docs not being in a position to say, no, you don't need that. And we do a lot of that through the disclosure and transparency sections, right? We think that patients have a right to know the cost, the quality, and the risks of what's done to them. So when a doc is saying, I don't think you need a CAT scan, it's 240 times the radiation for an X-ray, and it may not show us anything more. And here are the risk factors, and here's the cost to you out of pocket, and here's the other tools that may be available at our disposal. Now we're hoping that consumers say, okay, that's fair. You've given me all the information I need, because right now that information isn't even available to our doctors. Our doctors are ordering tests, and the payers are not providing them the information they potentially even need to make that decision.
From the point of view of the doctor, how do you respond to that?
Yeah, so the Institute of Medicine defines quality health care as sort of not too much and not too little. The right care for the right person and all of the time. And one of the things that I think will also evolve out of this is this sense that we are all on the same page and facing in the right direction, so that if I don't recommend a CAT scan to somebody, it's because I think that that's the most medically appropriate direction to go, that's what the evidence-based medicine perspective would tell me to do. And I'm hoping that will diminish patients' concern. Sometimes patients, if I say, well, I don't think you need a CAT scan, sometimes their response is, oh, it must be because the government's telling you not to do it or the insurance company's telling you not to do it. And I really want people to understand that if I recommend against a CAT scan, it's because I think that the risks and the burdens associated with that really greatly outweigh the benefits, and that we really have an alternative way to go. I think the idea of sort of being frank and open and being able to focus on prevention and making sure that people can have all the things that they need when they need it will hopefully diminish people's concern that somehow they're not getting what they're supposed to be getting. And I think once we can start to focus on that and really focus on what's important, it's going to make everybody more relaxed.
On the other hand, there are some viewers watching who may be thinking, well, how can I be sure, on the other hand, that I am getting the care that I need?
Well, let me just take that point, because that's a great point. But look at the patient satisfaction surveys. Most people really like their primary care provider, their primary care doctor. they're really happy. So why don't people necessarily go to their primary care doc? Why does someone present to the emergency room? They go to the emergency room because they can't get an appointment, they don't have a doc, or it's after hours. So the other things that we do is we say, look, we have 4,000 primary care docs and 6.4 million people, but 70% of them are located in 10 square miles of Boston. We have to encourage our consumers to sign up with a doc who's quarterbacking their health, or a provider who's quarterbacking their health. So we say that that's a must. Payers now have to keep track of who is the quarterback of your health. And we also look at using limited service clinics more, even in something like the flu shots. CVS, 24 hours a day, offering flu shots. Very important in this season where we're seeing an early flu. So we have to be able to provide other alternatives, health centers being open weekends and nights, to keep folks out of the ER and getting care in other settings. Now, if after all that, a consumer thinks they're not getting what they deserve, to your point, and they're concerned about that, this bill offers a second opinion to find out whether or not something is medically necessary if the consumer feels as though their care has been capitated or rationed in a way that puts them at risk. And it's very clear. We have a very robust Office of Patient Protection that hears appeals. So in the new ACO world, or Accountable Care Organization world, no patient feels as though, well, I might not get something because if I don't get something, that doc or that provider or that system has an opportunity to make more money off of me. We want to make sure that nobody is entering this new world with that kind of a fear.
I think we all know that the most expensive care that people can get is when they walk into the emergency room, especially with a condition that could have been treated with a primary care physician. What incentives are there now in this new law that would bring people? I think you're describing some of them to me.
Yeah, well, call 10 people and ask them if they want to be in the emergency room. Nobody wants to be there, waiting in line, and the worst place to be if you're sick is in a hospital. So I think that what the law does is it encourages and incents medical homes, accountable care organizations, folks that you can call that can get you in to see somebody more quickly, making sure there's someone, as I said, quarterbacking your health. It also incents limited service clinics and after-hour care so that if it is 8 o'clock or 9 o'clock at night, you can get somebody either on the phone or in person that keeps you out of the emergency room. We don't want people to go to the emergency room. We also look at scope of practices for primary care physicians, for nurse practitioners, and physician's assistants, right? We think primary care providers, that has to be a specialty. Primary care physicians should be treated as though they are specialists. And for a long time, that has not happened. So people too quickly are jumping to specialists. Our primary care physicians in this state are the best, right? And you look at all of the surveys on the primary care physicians, and you look at the level of satisfaction that patients have. They're generally more unhappy with their specialists. I don't want people leaving their primary care physician unless they absolutely have to. So one of the provisions of this law is make sure that there's a partnership between the primary care physician and the patient. And we not only encourage that, we suggest that that has to happen. A payer now has to keep track of who is quarterbacking your health. So when you go to an ER, they say, who's your primary care physician? And in real time, that primary care physician gets the information back from the emergency room as to what's happening with their patient.
And as one of the primary care physicians, here's your chance to talk about your profession and how important that is.
Right, so primary care physicians for adults, and so I'm a board certified internist. Family medicine physicians are also primary care physicians for adults, and of course pediatricians. And we view ourselves, we have training, we have board certification, and we feel capable of doing prevention and wellness and also chronic disease management, things like hypertension and asthma and hyperlipidemia. So very often we feel like we can provide a lot of care to patients, not only from a prevention perspective, but in an ongoing way. In my practice at Lahey now, we do have an evening clinic and weekend hours, and especially you can imagine with the influenza epidemic, our numbers have gone way up. But I think as much as that's been a lot of work for our practice, I think it's been better care for our patients, because I think otherwise in a previous day, people easily could have ended up in an emergency room, which is, emergency rooms are really designed to take care of people who are in trauma, have really an acute, emergent, life-threatening situation. But something like influenza, many people don't have to be admitted, they don't need fancy testing, they just need a good clinical evaluation and some supportive counseling about how to manage the situation. And that's exactly the type of thing that we want to keep doing in a primary care practice. So I think having the financial incentives aligned to give us the time and the space to really be that quarterback and figure out how best to take care of our patients is going to be enormously helpful. I'm the residency program director for the internal medicine program at Lahey, and across the country for years people have not wanted to go into primary care, in large part because there was this sort of growing amount of paperwork and burden, but also this growing amount of productivity in seeing patients. And you can only sort of have people do so much in any given day before they think, you know what, I need to find a different specialty. And we're hoping that with all of these changes, it's going to bring people back to wanting to be a primary care doctor, which for many of us is why we went to medical school, to help people, to have long-term relationships with people, to get to know them, their families, and to both keep them well, but also to be there for them if they do have an acute illness.
Thank you. I see our time is winding down. We're at the last few minutes of our show. So I'll turn to Chairman Walsh. Is there anything you want to leave our viewers with respect to how they're looking at the new healthcare financing laws?
Yeah, just a personal minute. You know, when my wife and I had twins 21 months ago now, and one of them was born with a very serious heart defect and a cleft lip and palate, and I was the chair at the time, and I was in the process of writing the bill. And she gave birth at the Brigham and Women, and I walked with one of the twins over to Children's Hospital, over the long and lonely bridge that separate the two facilities. And I wasn't thinking, what does this cost? Or is this a low-cost provider? I was thinking, get me the care now for my family and my loved one. I don't care what it costs, and I'm not worrying about if insurance going to cover it or anything else. And I think what we did, and I think Speaker DeLeo was clear on this, we protected that catastrophic incident. We made sure that no family will ever have to make that decision. So I just want folks not to worry. We want you to be healthier. We want you to be well. We want you to take more control of your own care and be a consumer advocate when it comes to your health care. But we don't want you to worry that care will not be available when you need it for you or a loved one. Because we have the best hospitals in the world in our region, and they should be used when we need them. And so no constituent of yours or any place else should ever think that this new law will put them in a position where their care will be limited in their time of need. We just want to help them to become healthier, and if we can save a little money in the process. For the last 10 years, we've cut education, local aid, public safety, the environment, social services, every single program that's important to you and the families you serve, we've cut to make up for the rising cost of healthcare. So if we can get that under control and begin to make investments in your community again, and we're healthier in the process, then this is a pretty good start.
That's a great point. Dr. Nilson, we've got about 30 seconds to
yeah, I would just echo that. I think that this is just going to give us the space to really be partners with patients so that we can give them the tools at home 365 days a year to take the best care they can of themselves, and then for us to try and keep them well when they have medical events. And the interesting thing in this over the country is that as we've begun to practice more evidence-based care and really focus on wellness, not only have we saved money, but we've had better clinical outcomes. So it really is a win-win situation.
Thank you. We could spend another 30 minutes talking about this topic, and I'm sure not exhaust it. So I appreciate both of you for coming, Representative Chairman Walsh.
Thank you.
And Dr. Nilson. And I'm Representative Ken Gordon. Tune in next time. We're going to talk about transportation. We talk about the MBTA, transportation funding, issues that are very prominent affecting our Commonwealth. Thank you very much.